Today to the point discussion is on pneumonia, risk factors, clinical features, general management, and complications of pneumonia will be discussed in great details in this video. Pneumonia is an inflammatory reaction of the substance of the lungs, which is usually caused by bacteria, but can also be caused by viruses and fungi. Clinically, it usually presents as an acute illness with cough, purulent sputum, breathlessness and fever, together with physical signs or radiological changes, compatible with consolidation of the lung. Pneumonia is usually classified by the setting in which the patient has contracted the infection. For example, community-acquired pneumonia is defined as pneumonia in a person with no underlying immunosuppression or malignancy. Hospital-acquired pneumonia are sometimes called healthcare-associated pneumonia, reflecting the role of other institutions such as nursing homes. Aspiration pneumonia, which is associated with the aspiration of food material or stomach contents into the lungs, and caused by impaired swallowing. Pneumonia in immunocompromised patient, which was acquired through either a genetic defect, immunosuppressive medication, or acquired immunodeficiency, as in human immunodeficiency virus infection. Ventilator-acquired pneumonia, acquired through mechanical ventilation on a critical care unit. Today focus is mainly on community-acquired pneumonia. Streptococcus pneumonia is the most common cause overall. However, in 30 to 50% of cases, no organism is identifiable, while in about 20% more than one organism is present. Infection can be localized when the whole of one or more lobes is affected. It is called as lobar pneumonia, and when diffuse, in which lobules of the lung are mainly affected, often due to infection centered on the bronchi and bronchioles, is called as bronchial pneumonia. Let's see the risk factors which lead to community-acquired pneumonia. Age, below 16 or above 65 years. Comorbidities like HIV infection, diabetes mellitus, chronic kidney disease, malnutrition, and recent viral respiratory infection. Other respiratory conditions like cystic fibrosis, bronchiectasis, chronic obstructive pulmonary disease, or obstructing lesion like endoluminal cancer, inhaled foreign body. Lifestyle factors like cigarette smoking, excess alcohol, and intravenous drug use. Iatrogenic immune suppressant therapy, including prolonged corticosteroids, are the common identified risk factors. Clinical presentation varies according to the immune state of the patient and the infecting agent. A dry or productive cough, sometimes with hemoptysis, breathlessness, fever, which, if swinging, may indicate empyema, chest pain commonly pleuritic in nature, and a pleural rub may be heard early in the illness with auscultation. Some extrapulmonary features like myalgia, arthralgia, malaise, myocarditis, pericarditis, and headache are common with atypical organisms like Mycoplasma pneumonia and Legionella. In the elderly, community-acquired pneumonia can present with confusion or non-specific symptoms, such as recurrent falls. Type and extent of investigations depend on the severity of the illness, and can be calculated with the help of CURB-65 score. C is for confusion and assessed using abbreviated mental test score below 8 out of 10. U is for plasma urea level, more than 7 mol per liter. R is for respiratory rate above 30 breath per minute. B is for systolic blood pressure below 90 mercury millimeters, and diastolic blood pressure below 60 mercury millimeters. 65 means bin age above 65, 1 point for each of the above criteria is given, and total calculated. Score 0 to 1 is treated as outpatient, score 2 is admitted to hospital, and score 3 or plus often require care in intensive treatment unit. Diagnostic microbiological tests are not done in mild infection, which should be treated at home with standard oral antibiotics like amoxicillin or clarithromycin for those with a history of penicillin allergy, and doesn't need chest X-ray routinely, unless they fail to improve after 48 to 72 hours. All patients admitted to hospital with suspected pneumonia should have a chest X-ray, blood tests, and microbiological tests. Radiological abnormalities can lag behind clinical signs. If chest X-ray is normal on presentation, repeat chest X-ray is done after 2 to 3 days. If community-acquired pneumonia is suspected clinically, full blood count, serum creatinine and electrolytes, biochemistry, and C-reactive protein are helpful in determining the causative organism. In Streptococcus pneumonia, white cell count is usually high, and inflammatory markers are significantly elevated. In mycoplasma, white cell count is usually normal, and in the presence of anemia, hemolysis should be ruled out by direct Coombs test and measurement of cold agglutinins. In Legionella pneumonia, there is lymphopenia without marked leukocytosis, hyponatremia, hypoalbuminemia, and high serum levels of liver aminotransferases. As other blood tests, sputum culture and blood cultures are required for all patients who have moderate to severe pneumonia, ideally before antibiotics are administered. In strep pneumonia infection, positive blood cultures indicate more severe disease with greater mortality. Arterial blood gas analysis is necessary if oxygen saturation is below 94%. An HIV test should be offered to all patients with pneumonia, since it is a common initial presenting illness in previously undiagnosed HIV infection. Let's move to the general management aspects of pneumonia. Supplemental oxygen should be administered to maintain saturations between 94% and 98% provided the patient is not at risk of carbon dioxide retention due to loss of hypoxic drive in COPD. In patients with known COPD, oxygen saturations should be maintained between 88% and 92%. Dehydration is common with less fluid and food intake. Intravenous fluids required in hypotensive patients, showing any evidence of volume depletion and hypotension. The first dose of antibiotics should be administered within 1 hour of identifying any high-risk criteria, and treatment should not be delayed while investigations are awaited. Parenteral antibiotics should be switched to oral once the temperature has settled for a period of 24 hours. Provided there is no contraindication to oral therapy. If patients fail to respond to initial treatment, microbiological advice should be sought and alternative diagnosis considered. The antibiotic regimen should be adjusted specifically once culture and sensitivity results are available. Thromboprophylaxis. If the patient is admitted for more than 12 hours, subcutaneous low molecular weight heparin should be prescribed, and thromboembolus deterrent stockings should be fitted unless contraindications exist. Physiotherapy. Chest physiotherapy is not needed unless sputum retention is an issue. Nutritional supplementation. Need is assessed by a dietitian, particularly in severe disease. Simple analgesia, such as paracetamol or an NSAID, helps treat pleuritic pain, thereby reducing the risk of further complications due to restricted breathing. Let's move to the complications of pneumonia. Number 1. Pleural effusion. Effusions are common with pneumonia and complicate around 1/3 to 1/2 of cases of community-acquired pneumonia. The majority of these are simple exudative effusions, but empyema may also develop, which is accumulation of purulent fluid in the pleural space. Ongoing fever and rising or persistently elevated inflammatory markers, despite appropriate antibiotic therapy, are the early indications of empyema. Number 3. Lung abscess, which is a severe localized suppuration within the lung associated with cavity formation, visible on the chest X-ray or CT scan, often with a fluid level, which always indicates an air-liquid interface, is also a complication of pneumonia. Clinical features usually include persisting or worsening pneumonia, associated with the production of large quantities of sputum, which is often foul-smelling due to the growth of anaerobic organisms. In chronic suppuration there may be finger clubbing as well. Pneumonia requires prompt diagnosis and appropriate management to prevent complications and improve outcome. Thank you for watching. Hope you enjoyed the video. See you next time with another detailed video.